there are several approaches that have been demonstrated to be efficacious in the treatment of advanced stage Hodgkin lymphoma. And some of the preferences for the treatment of this disease are geographic. In Germany and in parts of Europe, there's been a use of an aggressive regimen called escalated BACOP that over time has been modified to include less intensity and less toxicity for the patients. And this regimen, sometimes combined with radiation therapy, gives extremely high cure rates, but unfortunately does result in significant toxicities, including infertility and risk of secondary neoplasms. In the United States, and in fact in most of North America, the backbone regimen that has been used for at least 25 years has been ABVD. With this regimen, about 70 to 75% of patients with advanced stage Hodgkin lymphoma are cured. There have been several attempts to improve upon ABVD, and a big wave of studies looked at response-adapted therapy, where interim PET scanning was used, and if patients who had an early interim negative PET, say after 2 cycles of ABVD, there was demonstration that you could safely delete bleomycin then from the regimen and still have excellent outcomes. And for patients who had an interim positive PET, there seems to be some benefit to escalation at that point to a BACOP regimen. And the advantage of these response-adapted treatments are that you spare the toxicity of the escalated BACOP for everybody, presumably reserving it only for those patients who need it. However, long-term follow-up of these trials, for example, the SWOG 0816 trial and the RATHL trial, has demonstrated that the overall cure rate still is under 80%. So there's still room to improve. And that brings us to the Echelon 1 trial, which compared ABVD to AVD with Brentuximab, a conjugated anti-CD30 antibody. And the early results of this trial suggested a progression-free survival benefit, as well as some increased toxicity with the use of Brentuximab. However, for most patients, this was tolerable toxicity. And we've recently seen published, just a few months ago, long-term follow-up demonstrating an overall survival benefit to the Brentuximab-containing arm. And this, I think, was a surprise to some people because of the inherent salvageability of Hodgkin lymphoma. And presumably most of the patients who were treated on the ABVD arm had the opportunity to get Brentuximab in the context of a relapse. But despite that, there was an overall survival benefit demonstrated. And I think that does emphasize the importance of definitive cure up front, that as soon as a patient relapses, there are a lot of things that can happen. And things like autologous stem cell transplant portend additional risks of secondary cancers and other problems that you'd like to avoid. So for many patients right now, and certainly at our institution, the backbone regimen that we are using is the AVD Brentuximab regimen. And another advantage of this regimen is that it's not response adapted. You don't need to do a strict interpretation of an interim PET-CT, which in rural communities or communities that may not have sophisticated readers of PET scans can be hard to accomplish. I'll just add that the United States, actually North American intergroup through the National Clinical Trials Network, is wrapping up accrual to a study that is comparing the AVD Brentuximab regimen to AVD with nivolumab, a checkpoint inhibitor. This study accrued really in record time. It's going to be almost 1,000 patients that accrued over about a 3-year period. It accrued patients ages 12 and above. And ultimately, I'm optimistic that this trial will define the standard of care for advanced stage Hodgkin lymphoma. We'll have to see whether nivolumab is better than brentuximab, but this will be additional evidence that the brentuximab containing regimen is at least currently the standard.